heavy menstrual bleeding. Menstruation is the regular discharge of blood and mucosal tissue from the inner lining of the uterus through the vagina. The menstrual cycle is characterized by the rise and fall of hormones. Menstruation is triggered by falling progesterone levels and is a sign that pregnancy has not occurred. Immediately prior to menstruation, 3 distinct layers of endometrium can be seen. The basalis is the lower 25% of the endometrium, which will remain throughout menstruation and shows few changes during the menstrual cycle. The midportion is the stratum spongiosum with oedematous stroma and exhausted glands. The superficial portion, upper 25%, is the stratum compactum with prominent decidualized stromal cells. A fall in circulating levels of estrogen and progesterone approximately 14 days after ovulation leads to loss of tissue fluid, vasoconstriction of spiral arterioles and distal ischaemia. This results in tissue breakdown and loss of the upper layers, along with bleeding from fragments of the remaining arterioles, seen as menstrual bleeding. Enhanced fibrinolysis reduces clotting. The effects of estrogen and progesterone on the endometrium can be reproduced artificially, for example in patients taking the combined oral contraceptive pill or hormone replacement therapy (HRT), who experience a withdrawal bleed during their pill-free week each month. Vaginal bleeding will cease after 5–10 days as arterioles vasoconstrict and the endometrium begins to regenerate. Hemostasis in the uterine endometrium is different from hemostasis elsewhere in the body, as it does not involve the processes of clot formation and fibrosis. What is menorrhagia? Menorrhagia is heavy or prolonged menstrual bleeding more than 80 milliliters of blood per period. In reality, methods to quantify menstrual blood loss are both inaccurate and impractical. Many women have this type of abnormal uterine bleeding. It can be related to a number of conditions including problems with the uterus, hormone problems, or other conditions. Causes of heavy menstrual bleeding. Fibroids. 30% of heavy menstrual bleeding is associated with fibroids, adenomyosis. 70% of women experience heavy menstrual bleeding due to adenomyosis, endometrial polyps, coagulation disorders, pelvic inflammatory disease, thyroid diseases, drug therapy like warfarin, intrauterine devices that used as contraceptive methods, endometrial or cervical carcinoma. With a proper symptom analysis along with the appropriate investigations, underlying pathology can be identified. Symptoms associated with heavy menstrual bleeding like irregular bleeding, intermenstrual bleeding or postcoital bleeding may suggest an endometrial polyp, cervical polyp or other cervical abnormality. Excessive bleeding, bleeding from other sites, history of postpartum hemorrhage, postoperative bleeding, excessive bleeding with dental extractions and positive family history of bleeding disorders are suggestive of coagulation disorder. If the woman is having unusual vaginal discharges, she probably may have pelvic inflammatory disease, and if she experiences urinary symptoms like dysuria, frequency and urinary incontinence, abdominal mass and abdominal fullness, she might have a uterine fibroid. Weight changes, skin changes and fatigue may suggest thyroid disorder. After examining the patient for signs of anemia, it is important to perform an abdominal and pelvic examination in all women complaining of heavy menstrual bleeding. This enables any pelvic masses to be palpated, the cervix should be visualized for polyps or carcinoma, swabs should be taken if pelvic infection is suspected. Investigations. These investigations are useful guide for proper diagnosis of underlying pathology. Full blood count should be performed in all women. Coagulation screen is done only if heavy menstrual bleeding is there starting from menarche and if there is a family history of coagulation defects. Hormone testing should not be performed. Pelvic ultrasound scan should be done if history suggests structural or histological abnormalities such as postcoital bleeding, intermenstrual bleeding, pain or pressure symptoms, or enlarged uterus or vaginal mass is palpable on pelvic examination. High vaginal and endocervical swabs. Endometrial biopsy should be considered if there are risk factors such as age over 45, treatment failures or risk factors for endometrial pathology. Sensitivity of endometrial biopsy increases when performed in addition to using the cutoff of 4 mm endometrial thickness on transvaginal ultrasound scan. Thyroid function tests should only be carried out when the history is suggestive of a thyroid disorder. Management of heavy menstrual bleeding. Initial management of heavy menstrual bleeding in the absence of structural or histological abnormality should be medical. Levonorgestrel intrauterine system. It provides a highly effective alternative to surgical treatment with few side effects. Levonorgestrel intrauterine system should be considered in the majority of women as an alternative to surgical treatment. It is obviously not suitable for women wishing to conceive. Tranexamic acid, an antifibrinolytic that reduces blood loss by 50% and is taken during menstruation, or mefenamic acid, which inhibits prostaglandin synthesis and reduces blood loss by 30%, or combine oral contraceptive pills, which will induce slightly lighter periods. Norethisterone, taken 15 mg daily in a cyclical pattern from day 6 to day 26 of the menstrual cycle. Gonadotrophin-releasing hormone, GnRH, agonists. These drugs act on the pituitary to stop the production of estrogen, which results in amenorrhea. These are only used in the short term due to the resulting hypoestrogenic state that predisposes to osteoporosis. They may be used preoperatively to shrink fibroids or cause endometrial suppression to enhance visualization at hysteroscopy. In severe heavy menstrual bleeding, they can allow the patient the opportunity to improve their hemoglobin by providing a respite from bleeding. Surgical management. Surgical treatment is normally restricted to women for whom medical treatments have failed or where there are associated symptoms such as pressure symptoms from fibroids or polyps. Women wishing to preserve their fertility for future attempts at childbearing should be advised to use medical methods of treatment. Endometrial ablation. Ablation of the endometrial lining of the uterus to sufficient depth prevents regeneration of the endometrium. Ablation is suitable for women with a uterus no bigger than 10 weeks size and with fibroids less than 3 centimeters. Umbilical artery embolization, myomectomy. This may be a sensible option, or women with heavy menstrual bleeding secondary to large fibroids with pressure symptoms who wish to conceive. Thank you for watching.